Hey everyone, it's Denise Brown from the Caregiving Years Training Academy. Thank you so much for being with us today. We are here to talk about the path to the diagnosis. I wanted to share some insights about what that path looks like before we start our panel discussion. And if you're joining us live, we'd love for you to share your own insights in the chat room, and we'll also give you an opportunity to ask questions and share your own experiences. So in preparation for our conversation today, I thought, what does it look like in terms of numbers when we think about how long can it take to get the correct diagnosis? I didn't include statistics about how often people have to be diagnosed again, meaning that they receive the wrong diagnosis and then actually have to be re-diagnosed. But that is part of the experience as well. I thought this was interesting. On average, women receive a cancer diagnosis later than men. And when you look at other diseases, it could be as many as 4.5 years longer than it takes to diagnose a man. I'll share these slides for those of you who are joining live in an email that goes out this afternoon, if you'd like to take a look at the sources for the stats. And then I looked at one particular disease, and it was lupus, and it can take 6 years for individuals to receive the correct diagnosis. And it's from first noticing a symptom. And then 6 years later is when the correct diagnosis is received. And then when we think about a rare disease, it can take 4 to 5 years on average. However, there are some situations where it can take, can you imagine, 30 years. We also know that there's health inequity around the diagnostic process. And so I just looked at a couple stats that I thought could be helpful. And when we think about kids receiving a diagnosis, for instance, of ADHD, Black children receive the correct diagnosis 69% less than white children. And children who are from Latinx are 50% less likely. One of our certified caregiving consultants, Beverly, cares for her daughter. And she once shared the experience of trying to receive a diagnosis for her daughter who she knew was struggling. And she had a white counterpart at the same organization she worked at. And her white colleague received the same diagnosis for her child 2 years before Beverly could. And it was a nightmare for her to receive the diagnosis. And when she talks about that story, she talks about the toll. And that's what we're going to weave into our conversation today. What's the toll when the right diagnosis takes too long? And I came up with some bullet points, but this is not an inclusive list, so we can think about how to add to this list during our time today. Certainly distrust of the healthcare system. If you receive the wrong diagnosis, or if you're minimized in your conversations with doctors, you're going to think the system does not help me. The system does not help me. We also know that people of color have a difficult time getting the correct diagnosis because our diagnostic tools were built to diagnose people with, for instance, light skin. And we have not adjusted. The toll is also a delay in treatment. And the only way I could describe what that creates then is to say that it increases suffering. And if there's a better way to say that, please let me know. Please type in the chat room if you have a different way of thinking about that. That was the only way I could think about. How do we talk about a delay in treatment? Well, that means people suffer with their symptoms. And it's not just the physical suffering, right? It's the emotional suffering of not being heard, of being minimized, of people saying, oh, you're exaggerating, oh, it's all in your head. The impact then is not only on that patient, but also for the family caregiver. So it could be that family member who is attending the doctor's appointments with that family member and hears the same messages and experiences that same frustration. And then the family system. And think about the costs of going to doctor's appointments and never getting the right diagnosis. Think how much time is spent. Think about that working family caregiver, that working patient that's trying to organize these appointments, taking time off from work and still never getting the right answer. And there's an impact on relationships. And Sharon is going to talk about that when she talks about her story of her paths to diagnoses. And certainly there's the financial cost. I alluded to it when we think about trying to take time off from work to manage these doctor's appointments, but it can cost, depending on what your insurance plan is, and it costs the systems too. The systems pay the price when they don't diagnose patients accurately and quickly, because then we have sicker patients within the system. It helps everyone when we have correct and early diagnoses. Okay, so let's take a moment and introduce our panelists. So joining me today to share their own personal experiences of their own path to the diagnosis are Sharon and Jesus. Welcome, Sharon. Welcome, Jesus. Let's start with some quick introductions. Sharon, let's start with you. Would love to know about yourself and as well as about whom you've cared for and who you currently care for.
That's a long list, isn't it? I am Sharon Hall, and I currently care for my husband who has frontotemporal dementia. And you want to talk about a path? That's a path. I previously cared for my mother who lived with us when my husband was diagnosed, who also had a diagnosis of vascular dementia. And my father, who passed away shortly after I got them to move closer to me, and he died of kidney failure. And I have a son who went through a very bad path to diagnosis that ended up that could have been much less than it was. And I've become an advocate for particularly young onset dementia and also FTD because of the course that takes. And but I advocate for caregivers all the time across the board. But I've been doing that for since my husband's diagnosis almost 9 years ago.
Jesus, welcome. Thanks for being here today. Tell us a little bit about your situation and for whom you care.
Thank you so much. Good afternoon, everyone. My name is Jesus Loreto. I live in Miami, Florida. I've been a caregiver to my wife for the past 16 years. She was diagnosed with an autoimmune disease called Neuromyelitis Optica. She was quadriplegic in the beginning of the onset. She lost 90% of her eyesight. Now with DENS, now she sees better than me, 2020. I've been a caregiver advocate since the beginning, realizing that by telling our stories, we can help a lot of people. So I do run a support group every last Tuesday of the month on a Zoom call, and I also support Spanish-speaking patients and caregivers in the US and all over the world.
Okay. It's so hard to figure out where to start because it's such a huge topic, thinking about the path to the diagnosis. I wonder if we can start with, let's just for a moment talk only about ourselves. Let's just talk about the toll on ourselves when a family member has something wrong, but there's no name to it, and we know there's something wrong. What's it like to try to manage that? Sharon, let's start with you, and feel free to weave in the story of how hard it was to get the correct diagnosis for your husband, Rod.
Yeah, that was quite a challenge. Even though my husband's mother was diagnosed with Pick's disease, which is the old name for behavior variant frontotemporal dementia, even because that can only be diagnosed, Pick's can only be diagnosed at autopsy. So this is a clinical diagnosis. There aren't any tests for frontotemporal dementia. That was the reason it was so difficult, and is difficult for almost everyone that deals with frontotemporal dementia, is that behavior variant is a personality change, and you can put it off to many other things, and so do physicians. We're always pushed into a psychological bucket first. And so marriage counseling becomes our first test of the medical system and trying to find out what's wrong. And we go in saying, this is not the person I married. These are things that are happening that have never happened before and have never been a course of this person's life and our life as a married couple. And yet they continually say, well, it's a problem with the marriage, or it's a midlife crisis, or some stupid thing that isn't even a diagnosis. And you go through this, you get pushed into that black hole of psychology, and they're going to diagnose what they know. And most people don't know FTD. And certainly not the psychological community does not know, and certainly even the medical community. With frontotemporal dementia, primary care physicians see 0 to 2 in their entire career. Neurologists only see 5 to 10 in their entire career. It really takes a cognitive neurologist and it takes a neuropsychological test to really get to the bottom of it. We never would have gotten to the bottom of it. We would have been divorced had I not seen a video that talked about frontotemporal dementia and that it used to be Pick's disease. And I was like, oh, I know that my mother-in-law had passed away from this. And when I watched it, I had no idea the symptoms that were there that the family never talked about. The behavioral symptoms were never mentioned. And so consequently, I had no idea until I saw this video about it, that they even had behavior that my husband was exhibiting. And that put up the red flag for me. And in researching that, I discovered that it was very difficult to get a diagnosis. Usually takes an average of 4 years and 5 providers to get a diagnosis. And so I was not going to do that. I was going to go directly to the person that was closest to me that could do an accurate diagnosis, which was Emory. I live in the Atlanta area. And so I made an appointment, which was many, many, many months out. Yeah, I made the appointment in October. The appointment was in May. I knew that what I was looking at was frontotemporal dementia. It was without a doubt in my mind because of his history with his mother. But it was so far out that, and he was still working, and I was so afraid he was going to be losing his job because of the diagnosis. And so I was very, very concerned about that. Over Thanksgiving, which was a month later, he had a complete meltdown. I called Emory upon our return and said, either refer me to somebody that could see us sooner or get us in there because he's going to lose his job and I don't know what to do. And luckily they got us in. And basically from the first appointment, it was, this is very troubling. We'll go ahead and do all the testing, which took another month. But between the spinal fluid and the MRIs and everything else, neuropsych testing and so forth. It took another month to finalize that diagnosis, but I felt very privileged to have gotten it so quickly because I had looked into the fact that this is very highly misdiagnosed and underdiagnosed, and I wanted to go to someone that could accurately diagnose. But in the meantime, my mother was living with us who had vascular dementia. So I had 2 with dementia living in the home and called them the twins. And they would go to the day center together. And so I had two with dementia living with me at the same time.
And what's so frustrating is that the toll on you, Sharon, could have been your marriage.
It almost was. Had I not seen the video that was in October, I would have been filing for divorce in January because the year of marriage counseling was not going anywhere. And I said, okay, that's it. I've tried. I've tried to get us help. I've tried to, and I could see that he was trying, but it wasn't working. And I just wasn't willing to live in that situation any longer. So we were about 2 months away from me saying, that's it, I'm gone. And had I not seen the video, we would have been divorced prior, which is very common with FTD. Many, many, many people are divorced prior to diagnosis because nobody looks at the fact that I always say when someone is not who they were, think neurological before you go down that psychological path because you get stuck there. FTD is often misdiagnosed as bipolar, schizophrenia, depression, and none of that is true. But you have to go through that entire process and having it fail before you can get to somebody who might know what FTD is besides delivery of flowers.
Yeah. Yeah. Ruling out, right? The ruling out. We have to rule out everything else. And it's interesting because you talk about the number of providers that typically happens, which is part of that whole path. So it's not only number of years, but it's also number of providers. Thank you for that, Sharon.
Yeah, we
So
even went
he's,
back
oh,
to the marriage counselor after his diagnosis and said, we want you to be aware of this diagnosis and look at what you have been looking at. So if you have other people that come in doing the same thing that we said, this is not the person I married, and not getting any forward, that you can refer to neurology. Totally went over her head. Definitely was not part of her still tried to make suggestions on improvement. And I don't know how you improve missing neurons. I have yet to figure that one out. But just wanted to go to what she knew. And that is, let's continue working on this. And my husband became irate. And I said, I thought he was mad at me. I said, are you mad at me? And he goes, no, I'm mad at her. And put his finger in her face. And so that was the last time we went there. And I doubt that she learned anything because she wasn't willing to listen.
yeah, she was stuck in her silo. And that's the system. The system is this group of silos that don't necessarily interact. And so maybe you have your general practitioner who's in the middle and telling you which silo to go to get a diagnosis, but the silos don't talk to each other. You, the family caregiver, are the communicator between the silos, and you're trying to make sure that each silo has the current record, current medical record. And let's face it, that takes time, and that is not often a given that it's a correct medical record. Oh my gosh. Okay, Jesus, let's go to you. And I'm curious if you have something similar around the number of providers that you visited before you were able to actually receive the correct diagnosis.
Yes, when my wife started feeling some sensations on the back of her neck, some pain or burning sensation and tingling, she definitely recognized there was something wrong. So the first thing we did is go to the primary doctor. So we visited the primary doctor. He recommended to go to an ER because he hasn't seen anything like that before. So we went through 3 different hospitals in between about a week. All of them will say, no, I was stressed, no worries, just take a pill for the pain, it will go away. My wife insisted she wasn't feeling well, So I could say that our path to diagnosis was a journey. After 1 week, I called my brother. He's a medicine doctor down in South America, and he said, "Just hop her on a plane and send her down here." As I mentioned, we're in Miami. It took us about a 3-hour flight. She flew by herself because I was working that day. And when she arrived to the country, she couldn't get up from the plane seat. She was paralyzed. So they took her to a clinic, and they called me, and I flew in the next day. When I arrived there, she was quadriplegic already. They started doing different tests. The good thing is that at least they started doing some treatments for physical therapy, and they gave her some different prednisone and different medicines for the inflammation. And then it took us about 2 months because one of the doctors recognized that they could probably send the test to the Mayo Clinic here in the US. So they did a lumbar puncture, send the tests and the sample to Mayo Clinic, and we have to wait 2 months before the final diagnosis. For my experience after my wife's being diagnosed, and I've been very proactive of learning about the disease. And at that time, nobody knew much about it. We were very lucky because one of the doctors that saw her in South America just came back from the US from a congress, and she recognized some symptoms for an autoimmune disease called Neuromyelitis Optica. That's why she sent for the test. A test that was discovered about a year before, so we were very lucky. Once they diagnosed her, we started the right treatments. What I was saying that with the experience of the groups that I manage and all the work that we do in advocacy, my wife and I know patients that were misdiagnosed for decades and for many, many years. And the thing about autoimmune diseases, some of the symptoms relate to each other for different diseases, but the treatments are different. And if you treat somebody with MS, for example, with the disease, recognizing a disease as NMO, the treatments are not the same, and these are relapsing diseases, and they are progressive diseases. So if you don't apply the right treatment, the patient will always feel worse and worse until you find the right diagnosis.
Something that I have been thinking about of late is these weights that we have to manage. So it's waiting to get into the next specialist, waiting to hear test results. I'm curious. So Sharon, you were given a weight and you thought, okay, we can wait October to May, I think it was. And then it was clear a month later, we cannot wait. We cannot wait. I'm wondering if one of the things that we can figure out, and I have no idea what's possible around this, is these weights. First, I guess I'm wondering, Sharon, how do we endure these weights? Because nothing is changing, but the stress is additional because of the weights.
And it isn't getting any better
Yeah.
because when you're talking about these types of things that nobody recognizes or knows about, you have to get to a certain type of physician, and those physicians are so overwhelmed with people trying to get in because they've been around the block 75 times, and so it really is difficult. It's a lack of physicians who know diseases that are hard to diagnose. It's just a lack of them, and it isn't getting any better. It probably is getting worse. So it definitely is a challenge. You know, it's just a challenge to get in. And like what I did, I just said, you either have to refer me to somebody that knows, because I had a suspicion of what it was. Now, if I was totally unaware, oh my goodness, I don't know, I would have been stuck heaven knows how long. Well, I wouldn't have been, because I would have been gone. But you know, that I'm sure that Rod would have ended up under a bridge somewhere dying out in the cold, you know, because he would not have been able to manage. I mean, this is a progressive disease, brain disease. And as your brain deteriorates, you're going to get worse and worse. And since behavior variant is a lot of behavior, many people are even killed or incarcerated prior to being diagnosed because nobody recognizes what's going on. So I was fortunate in being able to say, I really think this is what it is, and finding the professional that could accurately diagnose that. But that is not normally the case with frontotemporal dementia. You just see these changes and you're desperately trying to figure out what's going on. And you get stuck in these loops of bipolar and schizophrenia and even, you know, and going further than that, incarceration for their aggressive behaviors. And it's just this loop, but really it's a lack of professionals and a lack of those professionals who don't know to try to get you to someone who does know. So an ego becomes involved. So this doctor is like, well, I know what I'm talking about, and this is XYZ for sure. Well, P.S., it isn't. And don't be so egotistical that you think you know everything. And so that's a real problem. That's a real issue. And so sometimes you have to doctor shop to find somebody who's even willing to refer you higher up to some other specialty, because some of the doctors will not do that. It's just the way it is. They have this ego. Did you find that, Jesus?
Well, we were, as I mentioned, very lucky, but the problem with autoimmune diseases is that when they are relapsing diseases, you have to monitor symptoms. When you see something wrong, you have to go to an ER right away, because inflammation, the results will be, people can die, people can be paralyzed, people can be blind. So even though after you have a diagnosis and you have a neurologist managing the disease, if you go to an ER, nobody in the ER will do what you tell them to do, because you know you already have learned about the disease, and you know they have to go through, do MRIs to recognize the inflammation, and then do rounds of solumetrol or do rounds of plasmapheresis. And they don't understand that. They go like, no, let's wait. And time is of an essence. Even though the patients are, we try to teach them, you know, how to manage that. We even created a patient card that they have with them when they go to an ER, or we tell them to go to the ER, which is in the same network as their neurologist, so they can call the neurologist and the neurologist can give them the instructions. But not everybody's lucky to live close to one hospital or you know, or to a large city where people will have all the resources to treat an attack. So it's always this, you know, tug of war with the system. We try to teach the system. My wife and I usually go to ERs. We bring brochures. We try to teach them, and we do, you know, Zoom calls. We have even traveled to neurology congress to let people know about the disease, because it's not a well-known disease. And as you mentioned, Sharon, some of the doctors will say, no, I know what's going on. I said, no, you don't know. Let me show you the information. Let me tell you, please, can you please call this doctor that really knows about this disease? And they go, yeah, we'll find the information, no worries. Also, another path that you have to take is when you get the treatments. My wife gets infusions every 6 months. And every time there is an infusion, something happens. They don't do the right measurements on the doses, or the infusion center the lady on the infusion center doesn't know how to do it, or the instructions get wrong. So it's always, you know, this navigating the system that is not easy. Not all patients or not all caregivers advocate for themselves. They don't learn much about the disease. So that's a problem at the end, because the patient can deteriorate if you don't do the right things.
There's a question in
think-
the chat for me there.
Yep.
Yeah.
Yeah,
Uh,
I'll read the question, then Sharon, we'd love for you to answer. So question is, Sharon, can you talk about how your husband's family handled his mother's disease process?
like an ostrich, head in the sand. Because behavior variant FTD exhibits many socially inappropriate things, it's hidden. People are ashamed. They don't want to admit what's going on. And so it's buried. It's not we did not live near my husband's family, and the people that were seeing what was happening were not talking to anybody about it. In fact, it was like, oh, she was diagnosed with Pick's disease. It's like Alzheimer's. It's nothing like Alzheimer's. There's nothing about it that looks like Alzheimer's. It would be like if Jesus' family said, oh, don't worry about it, Jesus. It's like breast cancer. Well, it's nothing like breast cancer. So it's the same kind of thing. And so they put it off and don't, and there's a stigma attached to dementia anyway. And because we don't talk about it enough, we don't talk about it as a deteriorating brain. We somehow think that people have free will over what's happening in their brain, and they don't. And so it's a huge societal problem as well. But the funny thing is, after Rod was diagnosed, he's from a family of 6 and 3 boys, 3 girls. And the 3 sisters came to our house. They were on their way to someplace and stopped for lunch. And oh, well, my goodness, what came out then was amazing. Oh, mother did this and mother did that and mother did this and that. And I'm like, you couldn't talk about this sooner? And ironically, we're absolutely certain that 2 of his sisters have FTD, will not acknowledge. One of them even called me, had a long job, 25 years in the same job, was getting written up for things that were very behavioral, were very FTD, called me and said, I think I have FTD. What should I do? I said, you go to University of Alabama, Birmingham, where your mother was diagnosed, and you say you have a family history of FTD, your brother's been diagnosed with it, and you think this is what's happening. Don't go anywhere else. Did she listen? No. Went to a local neuropsychologist who did testing without any background and said, oh, you're depressed. P.S. Within 6 months, she lost her job, all of her benefits, all of her retirement, everything. She didn't listen to me even, having had a diagnosis. So talk about family ignoring. And the other thing that is always bipolar. One of the nieces was diagnosed bipolar. It's not bipolar. I'm sure that niece has FTD. It's in the family, and yet they don't accept it. So what are you going to do? They hide it under a bushel and don't want the stigma of dementia to be in their family. But this is not controllable by the person. This is a deteriorating brain disease that ends in death. There is no treatment. There is no cure. It's only diagnosed clinically by a professional that knows what they're talking about. And yet the stigma continues. We go through that. I don't accept the stigma. My husband goes out. If he has an outburst in public, I just say, sorry, dementia. And I will have brochures about FTD if I have time to educate people. But we don't hide under a bushel basket. We go out there, and if people have to know that this, yes, it is not acceptable behavior, but it's because of a broken brain. And if you can't have compassion for that, I'm sorry, that's your problem, not mine. We're not going to sit at home because you don't understand a disease process.
Sharon, I wonder if you could talk about your son.
Yeah, that was a bad one.
Yeah, yeah, tell us how bad that was.
My son had been having GI issues for some time and had been going to a gastroenterologist and kept saying, I'm having these issues, I'm having these issues. Oh, it's irritable bowel. Oh, because he was only at that time in his 30s. And it's irritable bowel, it's this, it's that. Eventually, it got to the point where he was bleeding, and I said, "You don't leave that gastroenterologist's office until you have an appointment for a colonoscopy. No, it doesn't matter that you're only 44. You've been dealing with this for years and years, and you have to have a colonoscopy." Well, P.S. colonoscopy comes 3B colon cancer. So he had to have a foot of his intestines removed. It was in one lymph node, so he had to go through chemotherapy. This could have been a polyp removed many, many years before. But because of his age, it's ironic that I have been involved in two young onset diagnoses that were very very ignored. And so, yeah, just because of his age. And now you'll see that now the age for colonoscopy has been lowered to 45 because of the huge increase in people in their 20s and 30s being diagnosed. Luckily, he was only 3B. He has been clear for going on 5 years now. But so many are diagnosed at stage 4. So many with colon cancer are pass away in their 30s because they were never diagnosed in their 20s.
You know, Sharon and Jesus, we've had these conversations regularly, and I still am, my mouth just drops when you share the
He was
details.
diagnosed on his 44th birthday. And
I'm trying to,
be.
yeah, and I guess what I'm wondering is, we are advocates within this system. And Jesus, you have shared effective advocacy efforts to ensure that when, for instance, your wife goes to the ER, that immediately what she needs is taken care of. And yet it's still not acknowledged. I'm just wondering, how do you guys stay in the fight when the fight is so hard? Jesus, what do you think?
In my case, it's knowledge and also telling our story. We try to tell our story as much as we can through podcasts, through groups. We go to conferences. We have meetings with other patients and caregivers. And not everybody has the capacity or the time to learn about a disease, which is not easy, of course. I mean, to learn all this terminology or what's going on with your loved one. And you trust the doctors, but you continue, like Sharon said, sometimes you have to get a second opinion, definitely. When you realize or you notice that something is not right, get a second opinion. It's your right to do it, you know? Not all the doctors will know everything about it, all the diseases. In our case, we go through different neurologists until we find the right one. We do work with a foundation, and we do have a map all over the world of doctors that know about this specific disease. But as I mentioned, not everybody lives close to a doctor that will know about the disease. So how to connect with those doctors, how the doctors can communicate. I use online applications, and I print reports for all the doctors to see my wife. The primary doctor gets a report, even if we go only to see the neurologist. When I get a copy, I send it to him. Immunologist gets a report. The physical therapist gets a report. So that communication is important between them, especially when it's a rare disease. Rare diseases are very difficult to diagnose, and the path takes years and years and years. We were lucky, but I mean, my wife hopped on a plane walking by herself. And after 3 hours flight, she couldn't move. So time is of an essence to get a diagnosis. And it is important to educate yourself as a patient, as a caregiver, and have the most information that you can, so you can, navigate the path and the journey. It's not easy at all.
And I think that Jesus and I both have become advocates, and our stories matter.
Mhm.
And when people try to whitewash what happens with some of these diseases, particularly like dementia, and frontotemporal dementia, that's behavior variant, where it's very socially unacceptable behavior, and they try to whitewash. They don't want to talk about it. And even the associations that are supposed to be supporting you don't want to talk about it because they think that, it's this stigma. Well, if we don't talk about it and normalize the fact that these are diseases, these are not free will of just wanting to be a jerk to you, then it's never going to change. And you just have to be an advocate all the time. And I'm currently working with on a study about to for hospitalization of people with dementia. Believe me, you think people know dementia? Oh no, absolutely not, not in the least. And what you go through in a hospital with dementia is unbelievable. Just even Alzheimer's. I mean, we're not even talking about frontotemporal that nobody knows anything about it. And they try to always ask you if you know who the president is. And you're like, yeah, and I could tell you the presidents from the first one forward because my memory has nothing to do with my disease. And but they don't get it. But being in the hospital with dementia, holy moly. And I'm sure Jesus has the same. You've expressed that you go to the emergency room with explicit instructions, and yet they argue with you.
Yeah.
And this business of not listening to a care partner in the medical community is ridiculous. And yes, are you going to have some people that are hypochondriacs and they come up with and they doctor shop all the time? Sure, you're going to have that. But does that mean you ignore the people who have solid evidence of a disease and you're still going to poo-poo them? And I don't get it. I really don't get it. I don't understand why they're so adverse to learning. I mean, for heaven's sake.
Mm.
So you just gave me something that's helpful for us to think about and for us to do. And that is to document what's happening with our family members' health, or if it's in our situation, our health. And it could be a daily tracking of what's happening. And then it's also documenting the conversations with doctors and specialists and what's been ruled out. We are the expert of what our health is and what our family members' health is. And if we have the documentation, I think it can be helpful when we start that path to the diagnosis.
Yes.
Yeah, I'm curious what else you guys would add if we think about what's the best practices list when we're on this path.
Never give up.
Oh, I'm sorry. Exactly. Yeah.
Never give up.
Be
Never
resilient.
give up.
Be resilient and always learning or meeting with people, communicating your story and documenting, as you mentioned, Denise. Documenting is very important. Even the patient forgets, how did you feel 3 days ago? I forgot, or I don't know, or I took these new doses, or I changed for a new medicine. What were the reactions? What were the side effects? You have to document everything and as much information as you can. There are very good applications online that you can keep track of all that. And you can even print a report before you go visiting the doctor. So you will have a history of the changes that you experienced since the last time you saw him. And something also navigating the health system. I have changed works in the past 16 years, like 4 times. And every time I change works means I have to change insurance companies. When you change insurance companies, that is incredibly crazy, if I can say that word, because you have to start from the beginning all over again. And they don't cover this infusion. They don't do this. And this, let's change this medicine for this one. I said, no, I mean, we can't, because that's what's working for her. And it's navigating that path is very troublesome. definitely. Even though
And
you
time
are an advocate, even though
consuming.
you know what you're doing, but they don't listen to you. They don't.
Right. And it's time consuming. You have to go through these hoops that shouldn't be there. There are these barricades against care.
Mhm.
And it just they shouldn't be there. And yet they still don't, medical professionals as a whole, and if you are one, I'm sorry to tell you this, you don't listen.
Oh no, I mean
I'm sure
we
some of you do. I'm sure some people that are in the medical profession do listen, do refer, do think they don't know everything, but we come across more of them that are on the other side of that, who don't listen to what we're saying, who don't recognize, who think they know better than the person that's living with that person and has been living with that disease for many years. Uh, How could you possibly know that person as well as that person that's with them? You just can't. And, you know, have
In
some
our case,
humility.
we do understand it. My wife suffers from a rare disease. The word says it all. And not all the doctors will know about the disease. And we do understand not all the doctors will know about all the diseases, especially in the neurology area. But at least listen to what we're trying to say in the best way. We do have documentation, we do have statistics, and us because we're proactive. But what about those patients that they don't even know how to explain what they feel, or not all the patients have the luck to have a caregiver next to them. We as caregivers make most of the decisions when depending on the illness, sometimes the patient doesn't know or cannot express themselves. We're talking my wife, we're talking Sharon's husband or son, but what about pediatric patients that they don't know how to express themselves, or certain illnesses that they don't know how to explain what they're going through, and you have to go through different doctors and doctors and doctors until you find the right one. So it's not easy. It's a path that is not easy for patients or caregivers.
If they
I,
just
oh,
listen, just listen. That's the key, is just listen. Don't assume you know everything. The dementia is a word that we toss around that really has, first of all, has no medical. Dementia is so broad. There's over 100 and maybe 200 things that can cause dementia, many of which are reversible. But the neurodegenerative diseases like Alzheimer's and FTD and Lewy body and those that are neurodegenerative, uh, they, they're not, you can't treat them all the same. And you're not responsible for the fact that you have not been trained for these diseases that might be more rare. You are not responsible for that. I'm not saying it's your fault that you don't know FTD, that it isn't. It's the system that doesn't teach you that. But at least have the humility to say, I know that I haven't been trained in every aspect of every disease, of every rare disorder out there. So I'm going to listen to this care partner about their concerns and try to get them to the right person. That's all. That's all. Simple.
we are coming up on the close, and I just want to add a little bit of sunshine, a little bit of a ray of hope. There are community health workers who now will be reimbursed for providing services under the general supervision of a physician who can help with community health integration, which means finding resources in the community, as well as principal illness navigation, which includes listening to the story of a patient's path to diagnosis and what it's like to have that diagnosis. And the reason that this is important is that I think the healthcare system is too stressed for time. There isn't enough time. When we add in a new specialist, a community health worker, who is actually reimbursed for providing that time, it can help. And Jesus, to your point of what do we do when there's a patient that doesn't have an advocate? It's connecting them to a community health worker who has time to spend to help that patient prepare for a doctor's appointment, to help that patient and family caregiver figure out what are the questions we need to ask? What's the information we want? What's the referral we're requesting? It's helping that patient and family caregiver really prepare for those doctor's appointments so that they are effective and efficient, and really, hopefully, fingers crossed, minimize that path so that the patient receives the diagnosis in a timely, efficient, effective way. And I'll keep everyone posted on that. That's new to 2024. And I've been lucky enough to go to a lot of conferences to learn about how do we, in our work, add this and work effectively with physicians to make it happen.
And on the
Okay.
dementia front, the guide model is coming out.
Yes, yes.
And that is total dementia care, and very proud to say that the integrated memory care at Emory is a model for that. And so that will be much better for the dementia community when the guide, but unfortunately, if you're not on regular Medicare, it doesn't apply to you. So people with young onset who may have commercial insurance can't take benefit for that.
Right. And here's the good thing about community health workers with this community health integration and principal illness navigation. It is a Medicare Part B benefit. However, commercial payers can start to use a code to bill for it as well. So the hope is that this is the start of a new way to really address the needs of the community so that we keep our community healthy. That's what we've been talking about today, is how do we ensure that we receive the treatment and the support at the right time so that quality of life isn't something that we have to actually scream for. It's something that we receive at the right time in the right way that's right for us as individuals. Okay, Sharon and Jesus, this was fabulous. This was fabulous. Thank you guys so much for your time and for sharing your stories today.
Thank you for having us.
Thank you so much. Thank you.
And for those who are joining live, hold on and I'll share how to get your CEUs. And for those who are watching the archive, there's information about how to get your CEU in the show notes. Okay, thanks everyone. I'm Denise Brown. Please continue to join us. Our conversations about caregiving continue over the next 3 Thursdays. And you can go to caringourway.com for our archive and to learn about upcoming events that you can register to join us at. Okay, so thanks everybody.
Thank you.